So we're going to move on and talk about metastatic disease, and we're going to focus on metastatic triple-negative and HER2-positive disease, because last night we tackled the increasingly complicated world of ER-positive metastatic disease, and we'll keep Virginia here because there are a few things that came out at San Antonio and that we also want to pick her brains about. Welcome to Dr. Lowell Hart from FCS, who's going to be joining us today. Looking forward to hear what Lowell wants to ask the faculty. I just want to start out with a simple question to you, Hope, which is, what's your current second-line therapy in metastatic HER2-positive disease?
TDXD.
And the real question I want to ask you is, what's third line?
HER2-CLIMB.
And what do you think about the TDM1 plus tucatinib data? I think it's the COMPASS data.
It's toxic combination therapy and not clearly better than HER2-CLIMB1. So I think that most of us are really using the HER2-CLIMB1 approach. And also, we don't have data. The only ADC after ADC data we have, which is really cool, is with TDXD after TDM1. We don't have the reverse. And of course, those patients in HER2-CLIMB2 didn't receive TDXD. So I think that in general, I would still use the HER2-CLIMB1. I think there might be cases where you might think about that combination, but I have only given it in the COMPASS RD trial.
Interesting. Lowell, any questions you have about HER2-positive metastatic disease? Any cases where you've had issues?
Let's do TDXD. And again, if I'm a little bit sleepy, I had 1 hour sleep in the Atlanta airport last night.
So in order to come here,
it was like
you
being
slept
an intern
in the airport all night.
Really?
Yeah.
Wow. I did not know that.
It was like the old days of Jackson Memorial, U of M, back, which we all remember.
Get the colada.
1 hour sleep and get back to work. So one patient I kind of wanted to ask about is we can get to it a little bit later. It's a TDXD question. In HER2 low patient, but do you want to do that now, or should we? Sure.
Yeah, I think that is. We talked about that again a little bit last night. It's a big question in terms of HER2 low. What's your question, Lowell?
Yeah, well, I have a 74-year-old woman who was interestingly presented back in 2014 with stage 3 disease, and she actually went on NSABP B47 trial, and she got adjuvant chemotherapy and Herceptin. Did well, went on hormonal treatment after that, and did well. And finally, in about 2020, she relapsed with disease in pleura, lung, and nodes, and went on a number of hormonal treatments. We did look at ctDNA on her, found out she had ESR1. She had also PI3K, so she's been on both elacestrant as well as a PI3K drug, which was not all well tolerated by her. She's not going on AKT yet, but so we went back to look, and we rebiopsied her, and she's still ER and PR positive. She's HER2 0 on the rebiopsy. Her initial one was 1+. So about a year and a half ago, running out of options with her, I decided to try TDXD on her. And she's done extremely well with that, with minimal toxicity and an excellent response for a year and a half. So that's interesting. So I was looking for some excuse, based on the idea I felt it's probably a very potent drug, and looking for some excuse because I'm running out of other options with her.
Erika, how do you approach screening for ILD? Just in general with TDXD, whether you're using HER2 positive or HER2 low, this is an issue. And also, I've been commenting how different it is when we go outside of breast cancer, the lung people, GI people, et cetera. You hear different things. But now Lowell has this patient been on treatment for a year and a half. How do you approach initially the first few months? And what about later on? Particularly the issue of, scans and people are asymptomatic.
Yeah, in the clinical trials, we had scans every 6 weeks. That's just not doable, and an insurer is not going to pay to have scans within a 2-month interval. And so I typically do scans every 9 weeks, every 3 treatment cycles for my patients that are on TDXD. And typically for a therapy like a CDK or TDXD that you may be on for a long time, you start to maybe stretch those scans out a little bit, right? Not send that patient to the scanner all the time. But I think for how important it is to find ILD from TDXD when it's grade 1 and the patient has the potential to maybe go back on drug, I don't stretch my scans out. So I'm really keeping them at every 9 weeks for TDXD.
Virginia?
So we just had a case, Hope knows about this, with a grade 3 ILD on a patient on TDXD. And so I looked at a lot of data. There's not a lot of data with TDXD and ILD as far as treatment. And there are some risk factors, and I feel that it's very hard to do scans every 6 weeks. We don't do them either, but patients that have these risk factors, such as renal insufficiency, such as other lung comorbidities, I feel that these patients might benefit from that 6-week scan. And the reminder is that the median is around 10 months of getting ILD. So if we think, oh, let's just do the 6-week scans for the first couple months and then stop, that's not going to work either.
So Hope, you had a question, and also the issue, last night we had a patient who had ILD on everolimus, and then later on the patient got, I can't remember whose patient it was, the patient got TDXD and had pneumonitis, and then the question came up, what about prior pneumonitis? Is that a contraindication? And are all the pneumonitis the same pathophysiology? Any thoughts?
So yeah, the one thing I would say, the one caveat is that since 87% of the cases occur in the first year, if somebody's on for 4 years, you could probably do your scans less frequently, maybe in our 12-week timing or whatever. And then I think, for that patient, we don't really understand the risk factors of prior ILD because in the clinical trials, patients weren't allowed on who had prior ILD. So I think that it's something we have to be very cautious about. If a patient had enough pneumonitis with a prior drug to require steroids, you have to be cautious. Now, I would say TDXD is so effective in these patients who have ER-positive disease that I would still try it as long as that, the previous pneumonitis had completely resolved. It was some time, whether it was from a CDK4/6 inhibitor or everolimus or alpelisib or capivasertib. All these drugs have a low risk. But, we don't care so much about grade 1. We don't treat, we don't hold, only when they get symptomatic. So those are the patients we need to watch really carefully. And the other thing, just as a caveat, is a lot of people get fused PET CTs. These are non-diagnostic CTs. They are not adequate to pick up grade 1 ILD. And so I have seen a patient who died actually of TDXD ILD who was just getting PET CTs until she became symptomatic, and then they couldn't, she's an older patient, lots of prior treatment, but it was not reversible. So I think we have to be very cautious about the kind of imaging. These CT, diagnostic CT, non-contrast. You can use contrast, but you need to use a diagnostic CT.
So, Lowell, any questions?
No, so with grade 1 pneumonitis, once that's resolved, if the patient's, had a reasonable benefit, you would consider going back on the drug.
What about this thing about it has to resolve within 28 days or you dose reduce, Virginia? We were kind of talking about that, and we were polling the faculty about what they do. There's a little bit of variation about what people do. What do you do if they don't respond in 28 days? Do you dose reduce?
So the guidelines suggest that if it does resolve within 28 days, you can continue on the same dose. If it resolves past the 28 days, then you dose reduce. I'd feel comfortable dose reducing, honestly, regardless. And it also depends on whether you've given somebody steroids or not. That grade 1, there's also a question about whether you just want to let them resolve on its own. Although with steroids, it'll resolve quicker.
Any situations, Virginia, where you do preemptive dose reduction? At San Antonio the year before last, we had 2 patients in their 90s presented who got TDXD. They both responded, but the doc started out with a lower dose. You ever do that?
Rarely, but yes. So that would be the case where I would definitely consider doing that.
So let's take a look at some data. Erika, you put together some slides on HER2-positive metastatic disease.
I'm going to start with the case here. This is a 36-year-old woman who presented with de novo HER2-positive disease. She is a biologist that studies bats, so predominantly works at nights in caves. She has a 4- and a 2-year-old. She was diagnosed with de novo metastatic disease, had liver nodes, and unfortunately also had a single brain met. Her HER2 FISH ratio is 13.3, so definitely strongly HER2 driven. She received SRS to her brain lesion and then started THP responded well, continued the taxane for about 8 cycles. That was dropped out. And then she continued to get benefit for HP for 16 months. And, we see this, especially for these people that are strongly HER2-driven, that they really do continue to get benefit out of HP.
Well, also, she presents with metastatic disease. How big was her primary?
It was about 4 centimeters. Unfortunately, when you're in their 30s, there's no mammogram recommendations, and so really it's oftentimes somebody really feeling something, and with a 2-year-old, she had recently stopped breastfeeding, and so these things just go undetected, unfortunately. So she ended up with a new liver lesion and then also had 3 new small brain mets. She did SRS again to these and enrolled actually on the HER2-CLIMB trial. She did receive Kate-Trastuzumab. She needed a capecitabine dose reduction, which is not uncommon. And then she had 13 months benefit on this therapy. So again, kind of above the average of what we would expect, which I attribute to her FISH ratio of 13.3. And then she went on to receive trastuzumab deruxtecan. She did hold in cycle 4 for grade 1 ILD, only on scan, no symptoms at all, and resumed at the 28-day mark. And now she's been on this for 14 months.
I'm just kind of curious before you get into your talk, Hope. Again, I've been reflecting back because, again, we're hearing about HER2 from unusual places now, and a lot of people outside of breast are not as aggressive as you are about looking for ILD. Any comments on that, Hope? I don't know whether you've observed that or not, or we ever get involved with any people outside of breast cancer, but I almost think we need to get them to sit down with you all.
It's interesting. I have a senior fellow who looked at UCSF at patients who were retreated after ILD and is working with their pulmonologists. And it's really fascinating because the cases who weren't breast cancer were in general sicker when they were picked up. So I think that does resonate with what you're saying. They don't get these non-contrast CTs so frequently because there's just not as much data. So I do think that sort of a global approach to this will be really important. And there's some work going on trying to see whether or not PFTs, perish the thought because they're hard to schedule them, but PFTs or prone CT scans will be a better way of interpreting risk other than the renal insufficiency, age, and treatment. So I think that it will be interesting to see. We don't even know really if cigarette smoking, for example, increases your risk because so few of our patients smoke cigarettes who have breast cancer. So, but I will say that, when somebody's been heavily pretreated, they're elderly, something like that, these are the patients we generally start at a lower dose, but we're quicker to dose reduce for grade 1 ILD, which for this patient we wouldn't have. So
the other thing that's interesting, and Lowell, I'm sure you can empathize with this, is again, these other, we were talking about GYN this morning, biliary, et cetera, bladder, and the GU people go, oh, it was only 40 patients. But the oncologists out there know, because they've used TDXD, like your patient, a 1.5-year response, that this is not the normal agent in terms of duration of response. Right. You see that, Lowell, in terms of what you're hearing outside?
Yeah, I think so. And I think it's very complicated. And, I see a lot of lung cancer, too. And I've had a few patients that are, I've tried it in lung cancer. It's very complicated because of the fact they have, obviously, a lot of them have already had pneumonitis from radiation, thoracic radiation, chemotherapy, other things that they've had. So, and plus they don't have normal chest x-rays to start with or normal CT scans to start with. So it's very tricky in lung. You sort of have to, cross your fingers and hope for the best.
So yeah, there's a CD3 bispecific maybe coming to small cell. I'm curious how the lung cancer people are going to deal with CRS, but you all will know about that before it gets to lung cancer from the lymphomas and all. Okay, Erika, let's talk about some of the HER2 data that's
I'll give
out.
the one caveat that we're actually going to be presenting some updated data from Destiny Breast 03 at ASCO hopefully this year, and we were able to follow some of these patients that were on TDXD for a long time and look at updated incidence risks. I'll say that my only patient, I hope this is real wood, that I've ever had with grade 3 ILD did get it outside of the first year. She ended up hospitalized twice, and she was on a steroid taper for almost 5 months before she really recovered. Interestingly enough, she'd had such a profound response that she went on to receive no therapy for about 16 months before her cancer grew and then went back on therapy. But so I think, I don't know, it makes me worried of this narrative of after the first year, you're probably good on ILD.
And no recent infections or anything that might have triggered it, just out of the blue?
No.
All right, let's take a look at some data.
Okay, so just a refresher here that we in HER2-positive disease really think about kind of three classes of drugs. The monoclonal antibodies and trastuzumab and pertuzumab are kind of our oldies but goodies at this point, and margetuximab, that was our more recent data, but we can all get into a debate of the magnitude of benefit with margetuximab. HER2 tyrosine kinase inhibitors, neratinib and lapatinib, and what's really unique about the new one to the stage, tucatinib, is that it's HER2 specific, so really does not hit EGFR, and so we have a little bit less rash and diarrhea than we typically expect with tyrosine kinase inhibitors. And then over on the right, you see our antibody drug conjugates, and of course, trastuzumab deruxtecan is the new one, which really has some important biological differences than TDM1, which is why we see differential activity and differential populations where we see benefit. So this was the HER2-CLIMB trial. This was the registrational trial with tucatinib. And what was really unique about this trial at the time was they included patients with brain mets, and not just the typical patients we include, those that were treated and subsequently stable. They also included two higher risk populations, patients that were treated and then had brain mets that were progressing, or patients that had not had their brain mets treated. So really a higher risk population than we typically see. Patients had had prior treatment with trastuzumab, pertuzumab, and TDM1, so this was a so-called third-line trial, and patients received Kate-Traz or Kate-Traz tucatinib in a 2-to-1 randomization. So you can see here that whether we look at progression-free survival or overall survival, we saw a clear benefit. Our overall survival benefit was essentially about 17 months up to about 22 months. And based on this trial, tucatinib was approved. Interestingly, the FDA actually approved this essentially second line and beyond. And the reason being is they really didn't want a patient that had brain mets to not be able to get to the point to be able to have tucatinib. And so unusually, it was approved in kind of one line earlier than the clinical trial was really designed in. So that's an important caveat just to remember. So this was HER2-CLIMB-02 that we started the session talking about just briefly. This trial was really designed because TDM1 was the current standard in the second line. And so it was a trial looking at, could we bring tucatinib earlier? Well, while this was enrolling, trastuzumab deruxtecan came in and replaced TDM1 in the second line setting. And so I think this is why this trial is a little less actionable now than maybe it would have been if things hadn't changed. But this was TDM1 versus TDM1 tucatinib, and you see maybe smaller magnitude of benefit, but still a benefit here in progression-free survival, about 7.5 months up to 9.5 months.
What about that strategy in the post-neoadjuvant setting, combining tucatinib with TDM1?
So that trial is ongoing, looking, we haven't seen the results yet, but looking at tucatinib with TDM1, and then there's also a trial looking at TDM1 versus TDXD in the residual disease setting.
Yeah, that's an interesting thing to do in that situation. So, yeah, I mean, I guess the idea would be, so TDM1 really didn't reduce brain mets, though.
No. The spot that I would think about using this, and they had looked at some of the tucatinib data that even if you progressed, keeping that drug on board was still beneficial for brain mets. And we know that from HER2 disease that we reuse trastuzumab, having trastuzumab around is beneficial. So for somebody that has brain predominant disease and you get into that 4th, 5th line and you're thinking about using TDM1, I wouldn't really be hesitant to recycle tucatinib just for continued brain met control. So let's talk a little bit about trastuzumab deruxtecan. This is DESTINY-Breast02, and so this was really looking at Kate-Traz or capelapatinib versus TDXD. So this was kind of the third line trial, and DESTINY-Breast02 and DESTINY-Breast03 were actually kind of done at the same time. And so this trial ended up not as actionable as it otherwise would be because DESTINY-Breast03 came in and kind of made TDXD the standard in the second line setting, but this is still worth reporting. So median priors was 2. About 3/4 of patients had already seen pertuzumab, and you can see that about 40% of patients had seen endocrine therapy, kind of looking at who's hormone receptor positive versus not. And the progression-free survival benefit was 6.9 up to 17.8 months. So I think we can all agree that 11 months improvement in progression-free survival is significant. And our overall survival was even larger, over a year at 13 months. So again, why that trial maybe isn't as actionable for us in our daily practice is typically we're using trastuzumab deruxtecan earlier in the second line setting. And so this was DESTINY-Breast03, which was TDXD versus TDM1. And here we see progression-free survival improved by 22 months, almost 2 years. And we also see overall survival down here that was not quite significant at this point. But again, this is going to be presented again at ASCO this year. So what about side effects? And I think this is an important one because, as part of the clinical trials, DB02 and DB03, there were no mandatory antiemetics required as per protocol. We recognize that this drug certainly does cause nausea, and so NCCN guidelines, ESMO guidelines, ASCO guidelines all recommend at least the use of a 2-drug antiemetic regimen, and I think many of us actually use a 3-drug antiemetic regimen. I do in my clinic, and then I tailor from there. I think our nausea rates using those antiemetics are much better than what was actually presented in the trials. But you can see about 3/4 of patients having nausea. Was more rare for it to be grade 3, but certainly even grade 2 nausea can really be quite unfortunate for patients, especially on a drug that they may be on for a really long time. So just a caution to make sure that you're using those antiemetic drugs. I'll say that it's rare that my patients need more than 3, but sometimes when they do, olanzapine, 2.5 milligrams at night is actually really helpful. We kind of stole that from the GI literature, but that's what I use if I need something additional, and it really helps patients. We also can see thrombocytopenia. Most of the time this is mild, and I just highlighted this to show that thrombocytopenia at TDXD is much less of an issue with TDM1. TDM1 certainly grade 3 or greater was about 1/4 of patients. So I think we all acknowledge now that our systemic therapies for HER2 have really gotten quite a bit better, but what's plaguing us are brain metastases. I was telling Hope that I've had 2 patients that had pathologic complete response in the neoadjuvant setting and then have relapsed within the brain on their last cycle of adjuvant antibodies recently, and it's just so unfortunate. So I don't think I have to tell you that patients with CNS disease certainly have worse outcomes than their counterparts that don't. So let's dive into some of the data specifically around these drugs in terms of patients that had CNS disease. So I mentioned that in HER2-CLIMB, this was really a more aggressive trial in terms of who they enrolled. 48% of patients on the trial did have brain mets, and in terms of how those patients that with brain mets broke down, about 60% had active brain mets, so either the untreated or the treated and progressing, and about 40% of that, almost half, 48, had treated stable brain mets. So just keep that in mind. So this is the CNS data. You can see a CNS progression-free survival significantly improved, 4.1 months versus 9.5, hazard ratio 0.36 here. And overall survival, essentially a little under a year to almost 21 months. So risk of death in patients with active brain mets was reduced by 51%. So I'll give the caveat that I think most people are thinking about the HER2-CLIMB regimen in terms of brain mets and making sure that they don't miss this for their patients. But remember that the data for the 52% of patients on the trial that didn't have brain mets was also positive in terms of progression-free survival and overall survival. So I'm really using this regimen in the 3rd line regardless of whether people have brain mets or not. So what about trastuzumab deruxtecan? I think we were all a little bit more skeptical when we first started seeing data with trastuzumab deruxtecan, again, because the trials only included patients that had treated and stable brain mets. It really wasn't apples to apples. But we've had a lot more data come out. This is DEBRA, and you can see the very small numbers, 10, 7, 7, and 7, but looking at some higher risk populations, untreated brain mets, HER2 low and brain mets that have progressed, HER3 positive and meningeal carcinomatosis, for example. And this is the activity so we see. Certainly there are reports of having responses in the brain with TDM1, but nothing like this, where we're really seeing the majority of patients have benefit and meaningful shrinkage with trastuzumab deruxtecan. And so you can see progression-free survival at 9 months is over half of our patients with trastuzumab deruxtecan. This was Tuxedo 1, and this specifically looked at trastuzumab deruxtecan for patients that had active brain mets. Everyone had already seen trastuzumab and pertuzumab, so this is a very real-world population, and you can see the response rates by RANO-BM criteria. Essentially, 3/4 of our patients are responding. And so I think we can really put to rest that idea of, oh, TDXD is too big, it's not going to get into the brain. We're clearly seeing responses, and this is a very appropriate drug for patients with brain mets. So what about when we look, this was a pooled analysis, DESTINY-Breast01, DESTINY-Breast02, and DESTINY-Breast03 across patients that had HER2-positive disease. The majority of these patients that had brain mets were stable and treated, but there were some that had active. And so if we look at this, you can see TDXD here in blue compared to the green and black, really showing much better activity in terms of CNS responses than our comparator arms, which again, because it was 3 different trials, vary. And then if you look in the bottom right corner, for those patients that had untreated active brain mets, really no comparison. So I think we can feel quite confident with our TDXD data. Safety in summary, I'll generally just summarize this since we have a time issue, that there's no difference in patients that had brain mets versus those that don't. We still need to be aggressive on managing nausea, but this drug is tolerated quite well. So where's our current treatment algorithm? Last slide to summarize this. Currently, our standard is still taxane, trastuzumab, and pertuzumab, although we do have TDXD reporting out soon in clinical trials here that could change this. In the second-line setting, I say most of my patients receive trastuzumab deruxtecan. Just like HOPE, I'm giving HER2-Climb in the third-line setting, and then fourth-line and beyond is where it becomes a little bit more of a wild, wild west, with recycling ADCs, going to other TKIs, or looking into margetuximab, et cetera.
So a couple of questions from the audience. Virginia, K.S. Kumar, he's like the chief of our chat room. He's always there asking great questions. He's going to be co-moderating tomorrow. He has 2 patients, metastatic breast cancer, HER2-positive, doing well 6 and 7 years later. Pertuzumab was stopped, and both due to neuropathy. How long to go? One patient had solitary mets, the other multiple mets. We had a couple questions, and we keep hearing about cell-free DNA. I'll end with cell-free DNA help.
So they've had a complete response, clinical response?
It doesn't sound like it, but, well, maybe. 6 or 7 years, it sounds like it, yeah.
So if they've had a complete clinical response, people are going to look at 2 to 3 years of anti-HER2 therapy and then stop. Honestly, this seems to be a pretty easy answer for the patient. The patient's going to tell you what they want to do. So I typically just present the fact that we don't have a lot of data. We don't have any data on stopping anti-HER2 therapy, but a lot of these patients are quote-unquote cured from metastatic disease. And if they feel comfortable stopping, they will. Sometimes they'll stop one drug and then they'll stop the other drug. I will typically continue the HR therapy if they are HR positive. Now, if they have continued disease on imaging, obviously we're going to continue the therapy forever.
So Hope Salmon, as a 65-year-old woman, heavily pretreated HER2-positive disease, grade 2 pneumonitis on TDXD that completely resolved, then went through several other lines of therapy, and as a last resort, the patient was put on margetuximab-containing regimen, got grade 3 ILD. Has ILD been seen with margetuximab? So she was never able to find any data, or you haven't been able to find any data on that. Have you seen that?
No, we didn't see it in our phase 3 trial, and it hasn't been seen in the neoadjuvant trial either, that's looking at margetuximab in patients of specific pharmacogenomic subsets. So it really hasn't been, but I think that, if you have done some talks on ILD globally, and pretty much anything can cause ILD, so it's unlikely that patient received margetuximab alone. But for example, we know gemcitabine causes ILD, particularly in patients who had prior radiation. So I could see that really, and taxanes do, pretty much anything you partner with an antibody might, again, cause recurrent ILD if you've had it before. The other thing about the duration, we somehow picked up, people who had a great response, right? Complete response. usually de novo, but sometimes previously treated metastatic disease, and then we just give them arbitrarily 10 years of antibodies, which is totally made up. So there's a trial in the consortium that was called Stop HER, I think, where patients can stop at 3 to 5 years and then see what happens. And I think it's a great idea because we've not studied it at all.
Erika, Hope's going to talk about triple-negative disease. Shalini has a 44-year-old patient, triple-negative, BRCA negative with progressive brain mets, even after SRS, whole brain radiation, stable systemic disease, previously progressed on platinum, capecitabine. Any options for intracranial disease, Erika?
Yeah, I mean, that's challenging. Unlike these HER2 drugs, we really just don't have great drugs for CNS disease. I think across the board, now that we know, especially after radiation and local control, I mean, I'd be thinking about ADCs for this woman. Sacituzumab would be an option, trastuzumab deruxtecan if she had any HER2 low expression. So I'd probably be thinking about the ADCs.
All right, well, let's take a look at some data, Hope, looking at triple-negative metastatic disease.
Okay, so, obviously this is an area that's kind of torturous for all of us, my disclosures, and the case. So this is a 40-year-old woman who presented with a left breast mass, 2 centimeters, 1 enlarged node. Biopsy shows grade 3 IDC that's triple negative with HER2 AHC 0, and her Ki67 was 70% in breast. Node is also positive. Unfortunately, on her staging CT scan, although she had normal liver enzymes, she had multiple liver lesions, and a biopsy again showed triple negative disease. She felt pretty well, so it was all very shocking that she had liver metastases. So she had genetic testing which showed a BRCA1 pathogenic mutation. She had TP53 loss and an FGFR2 mutation. This is what we always see, nothing that you can target. And then a combined positive score came back at 12, so we're very excited about that. And she was treated with nab-paclitaxel and pembrolizumab, although she hadn't had prior taxane, so you could argue for paclitaxel. We gave her nab-paclitaxel. And she had complete resolution of liver lesions. There was a couple of little lesions left. So then she continued on pembro maintenance, but we had this long discussion about olaparib and olaparib plus pembro maintenance, and decided to add the olaparib, which she's continuing on now.
So second opinion, Virginia, is that what you would do in this situation? Add olaparib maintenance? Pretty creative.
It is pretty creative, and Hope presented the data at San Antonio that I'm hoping she will discuss here today. It's interesting data. I personally, as standard of care, continue the pembrolizumab without adding olaparib at this point, but I think it is extremely interesting that you're having an improvement in PFS with adding olaparib. Our GYN colleagues do this, so why not us?
So we'll get a third opinion. Erika, you're kind of half GYN in my opinion too. So let's get a thought about what do you think about this idea? PARP maintenance, certainly do that a lot in ovarian cancer.
Yeah, I have not adopted it across the board yet for breast. But I agree. I mean, I think we may be getting there. We're kind of ahead of everyone on ADCs, but I think we're probably behind others on PARP maintenance.
Yeah, I mean, prostate's trying to catch up too. I mean, they should be, I think, we'll talk about that this afternoon. Maybe I think it's going to land a little bit earlier, but of course, oncology, things often start late. All right, Hope, let's talk about some data. Let's talk about ADCs.
And I will say, I don't think we're ever going to have data on olaparib maintenance in breast cancer. And this disease has a median survival of less than 2 years. So what do we lose? That was my take. Okay, so of course, the big news in breast cancer was all about immunotherapy. Unfortunately, only 38% of patients have PD-L1 positive disease. And in KEYNOTE-355, we saw that the addition of pembrolizumab to a menu of chemotherapy, either gem, carbo, paclitaxel, or nab-paclitaxel, improved both progression-free and overall survival with almost a 7-month absolute improvement in overall survival in these patients. And the interesting thing was that when you looked at subset analyses, it appeared that patients did a little better with the taxanes and gem-carbo, but remember the patients who got gem-carbo generally had relapsed. You are allowed to go on study if you'd relapsed 6 months or more after your last treatment with curative intent, which of course I applaud since a lot of the trials now have 1 year mark, but it may be that those patients who relapse have a slightly less benefit if you relapse early. We also did an analysis and looked at patients who stopped their chemo after they had either a response or stable disease, and what we showed that those patients seemed to have a very long median overall survival compared to what we would expect, and that was true even in patients who had a PD-L1 CPS of 1 or greater, which is really interesting. And obviously this is all retrospective analyses that are only hypothesis generating, but quite intriguing. We also looked at something near and dear to my heart, which was what happened to patients who had immune-mediated adverse events. These data were presented at ESMO Breast and hopefully someday will be published. But this patients who had immune adverse events, similar to what we've seen in other diseases and really haven't looked at well in breast, seem to have a longer median overall survival and progression-free survival as well. Although again, you're getting into small numbers. If you look at the PD-L1 CPS of 10 or greater, you can see that there's really, in this small number of patients, 64 versus all patients, it was really a pretty marked difference. So again, quite intriguing and really suggests that we should be trying hard to continue pembro as long as patients don't have life-threatening toxicity like pneumonitis.
Did you look at the type of immune adverse effects? And I know probably not enough numbers, but the lung people, I've heard them say they think dermatologic toxicity is more predictive. And any thoughts?
We didn't. And interestingly, although rash is quite common, in our breast cancer patients, we tend to see endocrine toxicity as the most common. Certainly, any abnormality of the thyroid is more common than rash. At least in my experience, I don't actually see rash that much. So I don't think we would be able to really determine the type and the prediction.
Curious, Lowell, you see rash in lung?
Yeah,
I mean, I hear a lot about it.
In lung, yes. I have a woman with an African-American woman who got terrible vitiligo and has been off therapy now for 4 years with nothing happening, basically. Her skin's not a lot better, so, there are new drugs out for vitiligo, but I'm kind of afraid.
I haven't heard about that one.
I'm afraid to mess with it, so yes, I've definitely seen it in lung.
Was her PD-1 high?
What's that?
Her PD-1 was high?
Yes, PD-1 was high.
I've seen vitiligo in the neoadjuvant to adjuvant setting, and it's persistent. But both patients who had extensive vitiligo had it when they were children, and then it had resolved. And it came back like incredible vitiligo, and also this poliosis, loss of pigmentation in the hair. They had great response.
Wow.
But, adjuvant, so anyway.
Yeah.
Okay, so then, of course, we have PARP inhibitors. We had the data from Olympiad and Embraca. Olympiad reported substantially earlier than Embraca in terms of the results that we had, showing a significant improvement in progression-free survival, and interestingly, almost an identical benefit in the two studies. These patients were not allowed to have disease that was refractory to platinum agents, and most patients were not allowed to have platinum in the metastatic setting, but you can see these data published in 2018, 2017. And then most recently in the European Journal of Cancer, Mark Robeson published this data on extended follow-up of Olympiad in patients who were receiving olaparib versus standard of care chemotherapy. And you can see that there is a numeric improvement in overall survival. It goes from 14.7 to 22.6 months with a hazard ratio of 0.55. But this is an unplanned analysis, so it's not statistically significant. And there's also data that's been published looking at patients who'd had no treatment. So they were treated as first-line therapy, which is one of my interests in this whole maintenance idea. And those patients also seem to have an improvement in survival. Again, this isn't definitive, but it does suggest that we should be using the drug earlier in the course of therapy if possible. There were no AML and MDS cases with longer follow-up, which is really encouraging as well. There are 14 patients at the time of this publication who are still on olaparib, and 9% of patients received olaparib for more than 3 years. I have to say that in my clinic population, I haven't seen that quite as much. A lot of people with ER-positive disease after CDK4/6 inhibitors, which weren't available for this trial population, have received the olaparib just for a year before they're progressing. So I think it's an interesting area to explore a real-world data assessment on. There's also some additional data on maintenance. So Brocade 3 recently published in 2020 with an update recently, looked at patients getting paclitaxel carbo with or without veliparib. They all had germline BRCA mutated metastatic disease, but a lot of them stopped the chemo because it was incredible thrombocytopenia. We know that you have a PARP inhibitor, even a weaker one, with chemo, you get a lot of count suppression. And so these patients did, so they stopped their chemo early and continued on veliparib, and the patients who were on veliparib had this dramatic improvement in progression-free survival compared to patients on placebo, really giving you the idea that this maintenance strategy is very effective. In Keylink 009, which we presented at San Antonio, patients, regardless of their germline BRCA or CPS testing, received pembro and olaparib after an induction of pembro chemo with gemcarbo for advanced metastatic triple-negative disease. And in the patients, we didn't see any improved outcome in patients who received maintenance with pembro and olaparib versus continued gemcarbo and pembro, and a lot of people dropped their chemo and just continued on pembro alone. But when we looked at the patients who had tumor BRCA, because we didn't look at germline yet, but these are probably all germline BRCA mutation carriers, there was a trend towards improved PFS and OS. It's a small number of patients, but really a big difference in outcome. And then PARP inhibitors in patients with BRCA somatic mutations have been looked at. Olaparib expanded with a 50% PR rate. So this is something I think we generally do in clinical practice, although it's not approved. T-DXd have been tested in triple-negative disease in 58 patients as a cohort of the larger DESTINY-Breast04 trial and an exploratory analysis. And the drug was approved across ER and ER positive and negative because this data was so striking, with a dramatic improvement not only in progression-free survival, but also overall survival. And this is the updated data presented at ESMO. And remember, 40 patients received the T-DXd and 18 received treatment of physician choice, but it went from 8.3 to 17 months. So it's very impressive in the minority of patients with triple-negative disease who are HER2 low. And the events, in terms of adverse events updated, are shown here with a 1.1% mortality from ILD, so very important screening. Most of the events, however, were grade 1 and 2, and nausea is the most common toxicity. I also use a lot of olanzapine, which is very effective. We have a little bit of data from DB04 on retreatment of patients who had grade 1 ILD, and many of these patients seem to benefit significantly, but the retreatment rate was really low. And so we're presenting a pooled analysis at ESMO, but I think that what's important is to think about retreating because these patients have so much benefit from T-DXd. Of course, in triple-negative disease, the T-DXd has been evaluated where they're HER2 zero in the DAISY trial. Small number of patients, only 37 total, but in the HR-negative population, the PFS was only 2 months and median overall survival 10 months. So it's not clear what the efficacy is in HER2 zero triple-negative breast cancer, and HER2 ultra-low, so not quite zero, but not 1+, will be evaluated here, but only in HR-positive disease in DB06. So in general, we're not really pushing T-DXd in the HER2 zero triple-negative population. But sacituzumab govitecan, which was used in patients who had heavily pretreated metastatic triple-negative breast cancer, improved both the progression-free and overall survival. Patients had a median of 4 lines of prior chemo, but it included early stage, so it's about 3 lines in the metastatic setting. And the most common toxicity here is neutropenia, and then diarrhea, the next most common toxicity. And this does appear to be related to their pharmacogenomics, their UGT1A1 status, which people are used to checking who treat other cancers with irinotecan. But the small number of patients who had STAR28 homozygosity appeared to have more neutropenia and diarrhea in both ASCENT and TROPiCS-02 in the HR-positive population. We don't recommend upfront testing, but I think patients who have a lot of diarrhea could be tested, and certainly it encourages us to dose reduce early in patients who have more diarrhea, which can be difficult to control. There are numbers of studies looking at sacituzumab in the first-line setting, and also in combination with pembrolizumab, as well as in the post-neoadjuvant setting, as you heard in the previous setting. The Begonia trial looked at the TROP2 ADC datopotamab deruxtecan with durvalumab. This is first-line treatment for triple-negative breast cancer. Only 62 patients, but rather dramatic responses, as you can see in the waterfall plot. And then in the spaghetti plot in the bottom, they seem to be extremely durable. There may be, we don't really know what's going to happen to ILD when we give drugs that could cause a low rate of ILD plus a checkpoint inhibitor, but the rate was only 5%, and they were all grade 1 and 2, so that was encouraging. We've talked about the toxicity of datopotamab last night with the stomatitis. These patients didn't receive prophylaxis, which can markedly reduce the stomatitis. There are a number of studies going on testing datopotamab deruxtecan in both metastatic triple-negative breast cancer in the first-line setting and TROPION-Breast02 in combination with durvalumab and TROPION-Breast05, in TROPION-Breast03 in the post-neoadjuvant setting, and then a neoadjuvant setting with durvalumab as well. So really a lot of studies. It's very intriguing. The sequential therapy with ADCs in triple-negative breast cancer has been looked at retrospectively in a number of studies. This is just data that Laura Hubbard from my institution put together, multi-center data showing that in general PFS in the first ADC is better than the second, but sometimes the PFS is identical or better with the second ADC. So we really need to understand these differences over time. There are some prospective studies going on. The TRADE-DXd trial looking at TDXd and Dato-DXd, and then a registry sequencing study with sacituzumab by Laura Hubbard, and then there's a TDXd after sacituzumab, a sacituzumab after TDXd study in HR-positive and HER2-low disease being run by Rishma Matani out of Miami here. Patritumab, studied by Erika Hamilton and others here in the triple-negative group, 1 to 3 prior lines of chemo. And although this is very small here, there is color-coded data on the triple-negative population showing response irrespective of HER3 expression, similar to what we've seen with HER2-low disease, and quite durable. And we're very much hoping to study HER3-DXd moving forward now that Merck has working with Daiichi on this, but it remains to be seen. And Merck also has a TROP2 ADC that's being studied in triple-negative disease in patients who have residual disease after neoadjuvant therapy called MK-2870.
And patritumab also, of course, being studied in EGFR-positive lung cancer, interestingly enough. So just want to close out a couple more slides from San Antonio and Virginia. Hope was talking about something we're hearing a lot about, which is the question of sequencing of ADCs. These are a few slides, again, from that same talk, looking at some of the data that particularly came out at San Antonio, looking at ADC after ADC, also getting into sort of the mechanism of resistance with ADCs, which I'd be curious what your thoughts are. Any thoughts about these new findings?
So this is extremely important. We're facing it in clinic where we have to give an ADC, and then we're questioning, should we give chemotherapy in between and then give another ADC? And the data presented at San Antonio suggested that this sandwich approach isn't any better than just giving one ADC after the other. So that's another good piece of information that we have. And we have to, in real time, evaluate the toxicity and as well as the resistance to these ADCs. Is it the payload? Is it the receptor? Now we have two ADCs that are both TROP2 and have a topo-1 inhibitor. But then when we look at sacituzumab and TDXd, the receptor is different. So if we think that there's some HER2 mutation that's making the one ADC not work anymore, maybe the other one will. I think this is where it's going to be important for us to understand this, study it, and study it on that specific patient, because there's really good data being generated looking at specific mutations in topo-1 as well as mutations in the receptors that'll make a difference as far as what should be our strategy in clinic with these patients.
So final comment from Erika again. Any thoughts about, in targeted therapy, we have so many efforts looking at mechanisms of resistance, but again, what about ADCs?
Yeah, I think it's going to be a big question, and I don't think it's going to be a single thing. I think we're going to have patients that are resistant to the target, that have differential expression of that target. I think we're going to have payload resistance. I think we're going to have drug efflux channels. We've already seen in a autopsy series around TROP that there were actually mutations that made the drug not bind. So I think that this is going to become a little bit more complicated. I think when it comes down to it, I think we'll have less benefit for ADC after ADC, and the question is will that second ADC still beat chemo? And I think it still will.
All right. Well, thanks so much, Lowell. Thank you so much, particularly after you went through yesterday. And thanks to the panel. We'll be back talking about prostate cancer in 30 minutes.